Our next speaker is Dr. Stephanie Dancer from Scotland. Dr. Dancer is a consultant microbiologist at NHS Lanarkshire and is Professor of Microbiology at Edinburgh Napier University, Scotland. She has been editing the Journal of Hospital Infection for 20 years, 5 of them as editor-in-chief. She also edits the International Journal of Antimicrobial Agents in Infection, Disease, and Health. Dr. Dancer will present on transmission of SARS-CoV-2 in a Scottish hospital. Dr. Dancer.
Hello, Kevin, and hello, everybody. And thank you very much indeed for inviting me to take part in this extremely interesting international collaboration. I couldn't help but notice from the presentations that have already taken place that mine is just a little bit different. And that is because it's an intensely personal view of what actually happened in my health board in Scotland during the pandemic, and in particular, one very uncomfortable month or so in the middle of our biphasic second wave. So without any apologies, I want to get up close and personal to what it's like in a Scottish hospital in the middle of a pandemic. And so here we go. Well, if you're an infection control professional like me, then you're really interested in how this virus is transmitted between people. And admittedly, when it all burst upon the scene, we didn't know. There were 3 hypotheses. You could touch someone or an object that was contaminated and then transfer it yourself to your own respiratory or oral epithelia. Or you could come into contact with the large respiratory droplets that fly out of somebody's mouth, particularly when they cough or sneeze, which would land directly on your mucous membranes. Or you could breathe in tiny aerosol particles from the air. These are much smaller than respiratory droplets. You can't see them, and they float around in the air like cigarette smoke. It's known that these aerosols, even the tiniest ones, can contain more infectious virions than the larger droplets. So is the virus on surfaces that we touch? Well, yes, it is, because people have found it. But the trouble is, it doesn't grow in tissue culture very easily. It's an envelope virus, it's very fragile, and it's not happy to grow, it's difficult. So it's assumed that it's non-viable and non-infectious if you do find it on surfaces. Mind you, there was an experimental lab study that showed that it's very happy for 3 days on various surfaces. However, with the benefit of hindsight, we feel that direct contact and fomite transmission, whilst they are possible, they are probably not the usual mode of transmission. Is the virus in the air that we breathe? Well, that's a silly question, isn't it? Of course it is. I think we all know that by now. And I'm showing you some snippets from a paper that was one of the first to find viable virus in the air, which was collected 2 meters away from a patient who was infectious. And this was in the absence of our understood traditional aerosol generating procedures. The genomic sequence of that airborne virus was identical to that from the patient. So there didn't seem to be any reason why we should discount the risks from airborne transmission. Well, if you accept that we're breathing out infectious virus on respiratory particles, then where do they go? Well, it depends on the size. And I think it's important at this stage to make it quite clear that there is a whole continuum of sizes of respiratory particles. There are the larger ones, the so-called droplets, bigger than 100 microns, which fall straight away to the floor under the influence of gravity. And certainly this was what we thought was happening a year ago when the virus first burst onto the scene. However, there are much, much smaller respiratory particles, in particular the so-called aerosols, which are smaller than 100 microns. In fact, a lot of them are smaller than 1 micron, and these do not fall to the floor. They might do so in half an hour or so, or even longer, in stagnant indoor air. But they are quite capable of hanging suspended in the air for long periods of time. And this is potentially as much more than the 2 meters that we originally thought was our protective barrier. So inhaling aerosol is the main route of transmission, not maybe, not possibly, It is. And I would commend a recent commentary in the Lancet from colleagues where they've put together some almost irrefutable points which suggest that this is indeed the case. And I'm not going to go through all of them, but I will mention the super spreading events. For example, papers published on choir rehearsals, transport, public transport, and restaurants, where there is no way that all the patients that became infected from these events had direct contact, either with the one infectious person at the beginning or anything that they touched. It can only be explained really by short and long range aerosol in the air. And secondly, of course, I must mention this, that asymptomatic and pre-symptomatic shedding, and there's a lovely slide shown by the previous speaker, showing quite clearly how much virus can be transmitted from someone who doesn't yet know that they're actually infected. And it's quite possible that more than half the transmission events are from folk that are either asymptomatic or pre-symptomatic. Right, let's move to Scotland. Well, here you can see the rate of positive cases per 100,000 population in Scotland. And below that is an almost identical shaped graph, and that's NHS Lanarkshire, which is my health board. More of that in a moment. Now, the reason why the first wave, of course, is so flat is because we didn't have the capability for testing. So it doesn't look particularly significant, but of course, as we all know, it was a year ago and most uncomfortable. Now, our second wave, which I'm going to call biphasic, you can see the shape of it there in Scotland overall. You can also see that in Lanarkshire, we mirrored that very closely, but in actual fact, we had a much greater rate. And that was because we suffered greatly in Lanarkshire. I've taken this from one of our Scottish newspapers, the Scottish Sun, to show you the band across the bottom of Scotland almost, which was most highly affected by the coronavirus. And you can see the health boards there. There's about 14 in Scotland. We've got Lothian, which is houses our capital city, Edinburgh. We have Forth Valley, Greater Glasgow and Clyde, Lanarkshire right in the middle, squashed between Edinburgh and Glasgow, and Ayrshire. And the hospital I'm going to be looking at in detail, Hospital W, is right in the centre of the highest rate of coronavirus infection. Well, NHS Lanarkshire is a semi-rural health board, and we have 3 acute hospitals, and I've put how many beds we have, Hospital H, M and W. And whilst they all have a casualty department and intensive care and theatres and et cetera, all of them have some sort of specialty. And in particular, I'd like to point out that Hospital W, which is the one that we're going to be looking at, takes in all the orthopaedic trauma for the entire health board. Now, I'm going to be talking about clusters that happened in the 3 hospitals, and I need to define those now. The clusters in the hospital and indeed in our care homes in the community are defined as 2 or more patients and or staff that tested positive for the coronavirus and linked, of course, in space and time. So the usual definition you'd expect for an outbreak in a hospital. Now, this here shows you not the rate, but the number of cases, the total cases in Lanarkshire, across a little piece of that biphasic second wave. So you can see it starts at the 21st of October and goes on to the 24th of Feb. So this is coming down from that first peak of the second wave with a trough in the middle, which actually started in December or so. And the reason why I'm showing this is because firstly, it obviously looks, even though it's not a rate, just total numbers of cases, looks very much like the rate of cases I've already shown you from Scotland and Lanarkshire. But also to say that the bit that we're going to be interested in, round about the trough of this curve, was something that happened at one of the hospitals, which was in disparity with what was going on in the rest of the health board and in Scotland. Well, this beautifully illustrates my inept illustrative work with Excel. I've got a better figure for you in a moment. What's shown here is a 6-month study period starting from the 1st of October 2020 to the 31st of March 2021. And in the background, with a sort of dull-ish green, you can see the care homes. And these are the number of clusters, which actually meant closure of our care homes in the community across our health board. You'll see there are gaps between the lines on the graph, and that's because I only had the data from Monday to Friday, so the weekends are missing. And you can also see right in the middle of the wave, the trough, if you like, which beautifully mirrors what I've already shown you, there's two big gaps. The first one was Christmas, and the second one was New Year. Now have a look at the number of clusters that were happening in our 3 acute hospitals over this time. And you'll see that they were occurring, 2, 3 or so clusters in each of the hospitals until the first week in December, when something happened at Hospital W. And whilst cases were coming down in care homes and the number of clusters in care homes and in NHS Lanarkshire community and in Scotland, in one of our hospitals, the clusters were going up to the extent that by Christmas, virtually the whole hospital was closed. This is a little bit easier, perhaps, to see what was going on. It's exactly the same as the figure that I've just shown you, but I blocked in the weekends for you so that you can see in yellow there the number of clusters, discrete ward-based clusters at Hospital W that started just after the first week in December. Okay, what did we do? Let's go to the next slide. Well, as you would expect with all outbreaks, the outbreak committee is convened, and there are ward closures as soon as 2 or more patients are found to be positive for the coronavirus. And I have not said, and I should have done, that these wards were non-designated COVID wards. So these were wards which were for patients coming in for other things, but not for the coronavirus. So we instituted our enhanced cleaning. All the patients were being screened anyway. Staff screening didn't take place until almost the end of this particular flurry, so that was the 21st of December. Everyone was asked to mask, that's patients as well. We stopped visitors, etc., in very unusual circumstances. The surveillance continued, and we kept the respiratory masks, of course, for aerosol generating procedures. But in this case, the aerosol generating procedures were the usual traditional things like ventilation and so on. There was a ward ventilation review and a hospital walkabout in the week before Christmas to try and work out what was going on in the hospital at this time when cases were decreasing, and also because people were dying. Well, what cleaning did we do? Well, we normally clean our hospitals in Scotland with detergent. And only when a patient is known to have a particular pathogen on board, such as Clostridium difficile or MRSA, do we use the chlorine-containing disinfectant. However, by the time we realised what was going on at Hospital W, the high-risk pathway was employed for all areas of the hospital and not just the low-risk wards where we didn't think we had a problem. In actual fact, usually we did have a problem, we just didn't know about it. This was the poster that we put up to try and entice and explain and justify to our patients and staff why we needed everybody to wear a mask. Obviously, you can't wear a mask when you're eating or drinking, and some people, of course, could not tolerate a mask, and this was understood. Now, I've got no tangible figures on compliance, but to all intents and purposes, everybody tried to wear a mask at all times unless they were eating or drinking. Let's go to the next slide. There was so much discussion on toilets, so much. This is because we felt that the bathrooms, which were poorly ventilated, as had come out from our ventilation review, they are a hub where all the main transmission pathways of the coronavirus is likely to occur. For example, somebody who's infectious is breathing out into the air. And in a heavily used toilet, it means that the next person coming in within minutes is at risk. We also know, of course, that both urine and feces contain viable virus. And it's quite possible that flushing toilets creates plume, which would contribute to lingering virus in the air. Then, of course, you've got all the hand touch sites. So lots of discussion ensued about how we should manage toilets. How do you stay safe from COVID-19 in a toilet? We couldn't implement all of these. This is what we came up with. And there were some very simple reasons why not. We could ask everybody to wear a face mask going into the toilet, and that's what we did. And the windows, if there were any, generally they weren't, could be opened because our hospitals are naturally ventilated, except for theatres and ITU. We asked folk not to put toilet paper onto the floor. And we also asked folk to put the toilet lid down when it immediately transpired that very few of our toilets actually do have a toilet lid. So we couldn't put it down to try and inhibit the plume after flushing. Hand washing was okay. That was fair enough. And spending as little time in the toilet as possible was also okay. But we continued to believe that toilets perhaps are a main player in the spread of the virus, and they have not really been properly researched just yet. Let's move to the next slide. Well, this was something that was discussed around about Christmas time, where we had nearly the whole hospital closed because of the clusters appearing on ward after ward after ward. And we decided that because of work that had been done by the UK government, we should actually start opening the windows in our naturally ventilated hospitals. So we did a little bit of work looking at what guidelines had been published across Europe and elsewhere. And on 25th of January, we managed to implement the Open the Windows policy, whereby all the windows in our clinical areas were opened for 15 minutes, 3 times a day. Now, trying to get this through in a health board as a health board policy, you probably know how long that sort of thing takes. And this did actually take 3 weeks before we managed to implement it. But we got superb support from all the staff. We got the posters published. And again, no tangible figures on compliance. But as far as we know, clinical areas were complying and patients had extra blankets if required. So did the clusters resolve? Well, we'll see. You'll have to see what you think about this. But in total, across the health board, in our 3 acute hospitals, there were 40 discrete COVID clusters on the wards from the 1st of October until we started opening the windows. After we started opening the windows, there were 3 clusters before March the 31st. Now, Hospital W, which suffered completely because of these clusters, there were 17 involving 14 wards. Some of them lasted over a month. 42 days was the longest length of time with patients and staff infected. Each cluster involved an average of about 9 patients and 7 staff. And we also noticed that for most of those 17 clusters, I think it was about 13 or 14 of them, staff cases occurred first, and then a day or 2 later came the patients. So there were just 2 new clusters that we saw at Hospital W after the window opening. There was 1 new cluster at Hospital M, 6 weeks after the window opening, and after window opening, no clusters at all at Hospital H. So here's exactly the same figure that I showed you before, but there's 4 additions here, 3 blue arrows and 1 red arrow. Now, those 3 arrows designate when we experienced sub-zero temperatures. I mean, this is Scotland after all. And the first few days of sub-zero temperatures occurred just before the clusters took off at Hospital W. You can also see there, I hope, with the green from the care homes, that there had been a decreasing downward trend in the care home cluster numbers, but that levelled off as well. Now, 2 things to say about sub-zero temperatures. One is, we know this virus is very happy in the cold, so it survives better in the cold, including at sub-zero temperatures. We also know people's behaviour. You're most unlikely to open a window in a room when it's freezing temperatures outside. So the next bout of sub-zero temperatures occurred just before the 2nd week of January, during the 1st week of January, in fact. And we saw then the highest prevalence, if you like, of clusters amongst all 3 hospitals. By this time, they'd come down at Hospital W, but all 3 experienced clusters, 2 or 3 or so, for the month of January. And then finally, the last sub-zero temperature period occurred in the 2nd week of February, and there weren't any clusters there. Now, was that something to do with the fact that we were opening the windows, and the date of opening the windows is depicted by that red arrow just there? I don't know. But the care home clusters, which were not subject to the open window policy, you can see once again a downward rate is flattening off a bit there. And indeed, the rate accelerates a bit of clusters just after the second period of sub-zero temperatures. Let's move on. So, did the window opening have any effect in our hospitals in NHS Lanarkshire? And we've put together some points for and some points against, because without some fairly sophisticated modelling, I don't yet have an answer. But what I can tell you is that 40 clusters occurred in the hospitals, reduced to 3 after window opening. Now, at the time of window opening, we had one of the highest COVID-19 rates in the health board in the hospitals. We also had more care home clusters at the time, and much more than in December. There was a continued high number of patient admissions at Hospital W, so can't blame it on that, and I'll show you the data for that in a moment. And there were overall more COVID-19 patients in the hospitals at the time when we opened the windows. There was no change to the screening. Staff screening, which started on the 21st of December, didn't seem to have any effect, or certainly not with the high rate of clusters just after January cold weather. And patient boarding, which I'm going to talk about and show you a slide of in a moment, that was reduced at Hospital W, but not at the other two. So what are the points against? Well, as you've probably already worked out, we were already seeing the effects from a national lockdown on the 26th of December. So the overall rate in Scotland and in Lanarkshire was already decreasing. The care home clusters peaked on the 19th of Jan and then decreased very slowly over the following 3 months. Of course, a major player in this should be the staff vaccination programme, and that started on the 9th of December. And it was care home staff that were involved in that, as well as frontline staff in all 3 hospitals. But we were certainly vaccinating away at the time. Was it that had this effect? This is just the data to show you the total hospital admissions for all 3 hospitals from October to the end of February. And in particular, I've picked out those for Hospital W in red to show you that admissions actually went up a little bit in January and February. So we don't think that admissions had any impact on what clusters were happening in the hospital. Now, this is key, because I already said that Hospital W has centralised services for orthopaedic trauma. Those sub-zero temperatures in the first week of December had yet another effect, aside from virus survival and people not opening windows. It means that people have slips, trips and falls out in the community. And all the orthopaedic trauma for the entire health board was being sent to Wishaw. And because of the increasing number of clusters, patients were being moved around. Our orthopaedic trauma pathway is really quite complex, moving patients from admissions to care of the elderly on the ground floor to surgical and orthopaedic on the first floor. And you can also see maybe that the rate of orthopaedic boarding from the end of November up to about the 21st of December, well, it actually mirrors the way the number of hospital-acquired clusters took off at Hospital W. You can also see that the boarding was controlled from the second week in January and was coming down when we started opening the windows. Maybe too little, too late. So I'm going to summarise the genotyping data for Hospital W. We managed to send off some viral isolates from our patients from 9 wards from the 9th of December to Christmas time. And Health Protection Scotland very kindly did some genotyping for us. Let's have a look at the results on the next slide. Here are the results from 9 of the wards, and 7 of them, you can see straight away, had an identical phenotype. You can also see that we didn't have the so-called alpha or the Kent variant. We thought that maybe introduction of this highly transmissible strain from England was the reason for the number of hospital-acquired clusters at Hospital W, but that was not the case. What did Health Protection Scotland tell us about the conclusions? Let's look at that on the next slide. Well, there's always limitations of a snapshot, which in fact this was, because we didn't genotype all of the samples. But we were able to establish that there were multiple introductions from the community into the hospital, and that fitted in with our observations that it was staff that became positive before the patients for most of the clusters at Hospital W. We also saw that some of the introductions became established on one ward and perhaps didn't go any further, but others quickly spread to involve other wards. And we've got a lovely figure, which I wasn't able to get ready for you in time, to show how the hospital was overtaken from cluster to cluster, from ground floor to first floor, moving, if you like, with the number of patients that were being moved around because the hospital was becoming constrained due to lack of staff who were also symptomatic, and also lack of beds. And of course, no hospital ever has enough isolation rooms. Well, conclusions. We are sure that the coronavirus was introduced into all three of our hospitals from the community, and it was coming in through asymptomatic and pre-symptomatic staff. Now, despite the contact droplet precautions for everybody with the surgical masks, every hospital experienced COVID-19 clusters, and there is a mortality rate attached to that. Transmission occurred between staff and patients on individual wards, but for Hospital W, patients moving between wards initiated the outbreaks on unaffected wards. And this was, we think, orthopedic trauma cases. These fragile folk who need a lot of hands-on care were instrumental in, I'm afraid, taking the virus from ward to ward. This was confirmed with our genotyping, and the ventilation review, thanks to the Institute of Occupational Medicine in Edinburgh, there was a little bit of work done on the air changes in some of our naturally ventilated rooms to find that most of them were very much deficient. None of them came up to the rate of 6 air changes an hour for general wards or 10 for our toilets. The sub-zero temperatures and the possible association between cold weather and the taking off of clusters in hospitals is something that I think should be looked at in the future. And I think indeed will be looked at in the future, because if anything has happened with this terrible pandemic, it's the focus on infection prevention and control and transmission, which in fact is what we need for antimicrobial resistance, which is following along hot after this one. I think ventilation is now firmly ensconced on our infection prevention agenda, and I hope very much that it will stay so. Truly, the chapters of infection prevention and control are going to be rewritten after this pandemic. Did opening the windows help? I would like to think they did, but we've got a lot of modelling ongoing at the moment, and hopefully I'll be able to share that work with you as soon as I can in the future. So to finish off, I'd just like to acknowledge all the folk in NHS Lanarkshire on my final, almost my final slide, particularly the nurses on the wards, particularly the nurses on critical care and all the frontline staff in casualty as well, our infection control team, senior medics, our public health managers, our estates personnel, our cleaners, and finally the laboratory staff. Everybody pulled together. In fact, this conference gives me a parallel comment, and that is everybody is still pulling together. Thanks to Public Health Scotland for the extremely useful genotyping, and Miranda Lowe at the Institute of Occupational Medicine for doing the ventilation review, and finally the wonderful group of 36, the aerosol scientists, physicists, ventilation engineers and clinicians who've been instrumental in taking ventilation and plonking it right at the top of our agenda. So thanks very much. If we move to my final slide, I want to say that to my knowledge, we do not have a Scottish variant of pandemic proportion. Please, I hope that is the case. But if we do, you will be able to hear it coming. Thank you very much indeed for your comments and questions. Thank you.